Hello everyone, and in this session we are going to discuss a very important part, a very important part. Uh, Probably even if I take 10 people, then 6 or 7 must be suffering from it. So this is diabetes and diabetes mellitus. I'm talking about, not diabetes insipidus. Diabetes mellitus is basically an endocrine disorder, right? And we have type 1 and type 2 diabetes mellitus, which I will be discussing here. But let's first discuss about the diagnostic criteria of diabetes mellitus. So, we have the fasting blood glucose. First test we do is the fasting blood glucose. This criteria, just note that they are in accordance to the AHA, that is American Heart Association, right? So in diagnosis, the fasting blood glucose must be less than 100 milligram per deciliter. Pre-diabetes 100 to 126 and diabetes mellitus more than 126 milligram per deciliter. So this is the diagnostic criteria. More than 126 milligram per deciliter is considered to be a diabetic person, right? Then we have the postprandial or random or 2 hour after meal blood glucose. Okay, so we write this PPBG, that is postprandial blood glucose. This is FBS, FBG or FVS, we write fasting blood sugar or fasting blood glucose. So postprandial or random blood glucose, that is less than 140 is the normal range. And pre-diabetes we have 140 to 200, and in diabetes mellitus we have more than 200 milligram per deciliter. More than 200 milligram per deciliter. Then we have HB1AC, that is about long-term blood glucose. Less than 5.6% is the normal range. If I talk about the pre-diabetic condition or the impaired glucose tolerance, then we have 5.6 to 6.5. At this stage, we can advise the patient for lifestyle modifications, and if after that it is not treated, then more than 6.5. Actually, this HB1AC is a long-term indicator of this blood glucose, and more than 6.5% is considered to be a person with diabetes, right? So this is the HB1AC. So we talked about the diagnostic criteria of diabetes mellitus, and now let's move ahead. Okay, so let's move ahead. So we have the drugs for diabetes mellitus. So we have the first one is the insulin, right? You all have heard about it. Then we have OHA, that is oral hypoglycemic agents, or AHA, anti-hypoglycemic agents. Okay, OHA is also called as AHA. But some OHA, we don't use this term OHA because it is oral, right? It is oral, right? So we use the term AHA because some OHAs are injectable, like pramlintide. Pramlintide. Some drugs like pramlintide are injectable. That's why you use the term AHA. It's a better term, right? These are reducing the HbA1c, that is the chronic reduction, right? And we have to treat the long-term complications of diabetes. You can have macrovascular or microvascular complications, right? We can have diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, right? You will have these conditions. We can have other conditions like atherosclerosis and various miscellaneous conditions which you have to treat in a patient and have to reduce that complication so as to give the patient a optimized treatment, right? So here in complications, we have macrovascular or microvascular. So in macrovascular complications, you can see and have a visual prognosis and diagnosis is macrovascular, right? MI or CAD. Okay, myocardial infarction, coronary artery disease. You can have strokes. You can have perivascular disease. Okay, PVD, that is constriction of the end arterioles, right? You can have something called as a Raynaud's phenomena. We can have something as a gangrene, right? These all things are there in your macrovascular complications. Most patients present with a non-healing leg ulcer, even, right? Microvascular, we can have retinopathy, nephropathy, and neuropathy. Retinopathy, nephropathy, and neuropathy. Okay, so this much things you have to know in diabetes. And now let's move on to the types. We have the type 1 diabetes mellitus and type 2 diabetes mellitus. Okay, type 1 and type 2 diabetes mellitus. Type 1 diabetes mellitus is basically an autoimmune disease. Type 1 diabetes mellitus is basically an autoimmune disease, right? So here antibodies are produced against the beta cells of pancreas. So whenever I talked about pancreas, pancreas is a mixocrine gland. So you have an endocrine portion and an exocrine portion. So I am not talking about this exocrine portion. I am talking about the endocrine portion. Here you have something called as the islets of Langerhans. And in the islets of Langerhans, you can have alpha cells, beta cells, gamma cells, and delta cells. Right? So you can just omit the gamma cells and use that. Alpha cells are secreting your glucagon, beta cells are secreting the insulin, and delta cells somatostatin. Right? So this much things you have to know. Okay, so antibodies are produced against the beta cells of pancreas which are secreting insulin. So insulin is not secreted. So if insulin is not secreted in treatment, what you have to give? Very easy. Insulin also. Insulin only. Insulin. Plus two oral drugs. Insulin is always injectable, right? Just a minute. Okay. So here we have two oral hypoglycemic agents also approved in case of diabetes, right? We have acarbose and pramlintide. This pramlintide is given subcutaneously. This acarbose and pramlintide are two oral hypoglycemic agents which are approved in diabetes. Understood? Then we have the type 2 diabetes mellitus. Type 2 diabetes mellitus, it's the most common type of diabetes mellitus because it is associated with the sedentary lifestyle. It's associated with metabolic syndrome. It's associated with obesity, right? Here we have the peripheral resistance to insulin. Here we have a peripheral resistance to production of insulin. Okay, basically the beta cells are working well. Yes, the beta cells are working well. There is no auto antibody production. But what happens is that whenever the beta cells is secreting insulin, our cells of the body are resistant to insulin. The cells of the body are resistant to insulin and they are not able to utilize insulin. That's why the blood glucose level is shooting up, right? So it is the cells are not responding to insulin. So it is a metabolic disorder. It is a metabolic disorder. Obesity, sedentary lifestyle, increased calorie diet, anabolism in the body, decreased response to cells are responsible for this. Okay. So in metabolic syndrome, what three conditions you have? One is dyslipidemia. Dyslipidemia, that is abnormal lipid metabolism. Dyslipidemia or hypolipidemia, I can say. Okay. In the treatment, you have statins, fibrates, niacin, and all such drugs. Dyslipidemia. Plus, you have the hypertension. Hypertension, you all know what are the first line drugs in hypertension. Okay, you have your ACE inhibitors, you have your beta blockers, right? Beta blockers, and you have your calcium channel blockers, right? These all are your hypertension plus diabetes mellitus. So dyslipidemia plus metabolic syndrome plus diabetic plus this hypertension plus diabetes mellitus is basically metabolic syndrome. Okay, it's very important. Here in type 2 diabetes, what is the drug of choice in type 1 diabetes mellitus? Best drug is insulin, and other two drugs that is approved are acarbose and pramlintide. These are for type 1. In the type 2 diabetes mellitus, you have metformin. Metformin. Okay. You had in biguanides, you have two one. This is metformin, and one is called the fenformin. This fenformin was banned due to lactic acidosis. We have only metformin now, and metformin. Then we add other oral hypoglycemic agents, and then we add insulin at the end. Okay, so insulin is not much needed. First, you have to advise the patient for lifestyle modifications. Lifestyle modifications. Then, secondly, you give metformin. Then you add, and the third thing that after adding, after it is not controlled, you have to give the insulin. Okay, insulin. And if insulin is even not working, then you add some other like ganglion blockers and all, right? Then gestational diabetes mellitus. Okay, gestational diabetes mellitus related to pregnancy. Three drugs are approved: insulin, metformin, and glyburide. Insulin, metformin, and glyburide. Okay, done. So this finishes our discussion on introduction to diabetes mellitus. Let's move on to some other important parts here. So with this, we'll continue in the next session, and the subsequent parts will be covered there. That's all in today's session. Thank you, and keep watching.